any issue with this, please do let us know in the chat, and or you can reach out to any one of us personally. I request if all of you can please keep yourself on mute unless there's a pressing question that you want to raise. If you do still have a question, we request if you can use the chat option for posting questions and comments. We will try and answer as many questions as possible at the end of all the presentations. However, in interest of time, questions which have been liked or reiterated by multiple attendees will be prioritized. If there are any questions that have not been answered, we will try and create a Q&A or an FAQ document which we can upload on the Fuse website after this event. I'd also like to remind that we'll be uploading the slides and the research brief from 2 of the studies that we are presenting here today on the Fuse website after the event, and we'll share the link with everyone. I'd also like to, before I hand it over, I'd like to thank our speakers today for really coming here and presenting their work, but also to the team here, which the Fuse team, Mark, Cheryl, Leslie, everyone else at Fuse who've helped put together this presentation. And then, of course, all of you for joining in and giving us your time this afternoon. But this, I'll just hand over to Sheena to get us started.
Great, thanks very much, Neha. And yeah, very warm welcome to all of you. It's great that there's so many of you joined this afternoon. So I'm Sheena Ramsey. I'm Professor of Public Health Epidemiology at Newcastle University and Director of Fuse that Neha has just introduced. Our Center for Translational Research in Public Health. So I'll just start off with giving a bit of a background and context as to why we are looking at this particular topic this afternoon, really from a research and evidence perspective, and then I'll be followed by my colleagues Jill Harland, who's consultant in public health at Northumbria Healthcare Foundation Trust, and Peter Miller, who's the managing director at Horizons Northeast. And a lot of the work that we're presenting here today has been conducted very much in collaboration with Jill and Peter and other partners across the health and care system. There will be time for questions. We'll have a Q&A, as Neha said, later on. And even though we're not meeting in person, it's really great that a number of colleagues have actually been able to join online, and hopefully our interaction session will provide us lots more opportunity to have that discussion a bit later. But I'll just start off with a brief, just to share a few slides. Can you see my slides? Yeah, you can. Okay, great. So why are we thinking about the health of people experiencing multiple disadvantage and really thinking about what's the role for research? Well, I guess from a research and evidence perspective, that our research really needs to follow need, and with that, of course, many of you will be familiar with the terms of multiple disadvantage, which I sort of came across that about 6 or 7 years ago, actually with the health needs assessment as well that Jill Harland had conducted at the time at Gateshead Council. This was a report published by the Lankelly Chase Foundation, really recognizing and acknowledging the fact that many forms of disadvantages don't occur in isolation, but in fact they co-occur. So people who are experiencing homelessness are also dealing with issues of substance use, contact with the criminal justice system, but that's not in isolation. There are a number of other disadvantages and factors at play, like socioeconomic deprivation, poverty, unemployment, and adverse childhood experiences. All of these issues together actually have then an impact, and not just an additive impact, in fact, a multiplicative impact on the health outcomes of populations experiencing these challenges and issues. And that then impacts physical health, mental health, and also oral health, the dental health of populations, which really is of course linked with physical health as well as mental health and well-being. And in some ways, all of these issues together are sort of almost cyclical in nature. So these disadvantages have an impact on health outcomes, on health behaviors, and that in turn can further worsen the circumstances that people are in. And in some ways, this sort of issue of multiple disadvantage, I think, really brings to the fore the fundamental determinants of health of individuals and populations. And we know that that a lot of the factors that influence health are in fact outside of health, really, and it's the social, material, cultural, structural, environmental issues and the conditions that we live in, we work in, that we grow in, that really have an impact on our lives and on the health of populations. And it is these conditions that sadly have been worsening in our country. So we've seen on the left-hand side here the percentage of people living in relative poverty, which has gone up, and even lack of basic essentials. With the cost of living crisis, the number of people dealing with that has also increased. We've seen indicators such as the rise in child poverty as well, some of the highest levels that we see in the UK, and all of these indicative of these issues of multiple forms of disadvantages really linked with those structural material forms of deprivation. And it is really all of those things that again have increased that need, increased that worsening of health outcomes in populations. The issues of digital poverty have worsened, inequity in care has increased. But with that need, of course, it's also highlighted the need for how do we go about formulating evidence-based solutions. And for that, of course, we need, given the determinants of health and where they lie, we need that cross-sector collaboration, but also very much need that voice of communities, of users in our research. And it's these aspects that have driven us and my colleagues here thinking about how can we be thinking about our research that's really responsive to those needs, thinking about not just informing health services, but also health policy, thinking about some of the neglected populations, perhaps those living in rural coastal areas of our region, but also neglected aspects traditionally of trauma, mental health, oral health. But we're thinking not just of how do we respond to those needs in the form of research that we do, but also how do we move that forward? How does that research and evidence then translate and move things into policy practice? And that's where we're actively working with partners across the health and care system, and of course, people with lived experience. So that's just briefly a bit of an overview from me as to why we're thinking about these issues, what the value of this is in terms of really bringing about research and evidence that can change policy and practice. And I'm now passing on to Jill, who'll be up next. As I said, there'll be time for questions and comments, and we really value that. Please keep that going in the chat box.
Sorry, I'm just trying to
Sure.
share my slides. Let's find them.
If you'd like me to share, Jill, let me know.
I will. I think I found them. Let's just see. Are they showing?
Not yet, Jill.
No.
On the way.
Okay. If not, we'll revert.
Something's happening. Hang on. Yeah, I can see it now.
And are they on the right show? Can you see them?
Perfect.
Yeah. Okay, brilliant. Okay, afternoon, everyone. So I'm Jill. I'm a consultant in public health and I work at Northumbria Healthcare Trust. And I'm just going to give a very brief overview of, I guess, some of the experiences we've had looking at this issue through a NHS healthcare lens. And I think one of my key points is that there's lots of different ways of looking at the issue of multiple and severe disadvantage. And I think it's important that we understand those different lenses, but also how we can bring the lenses together to form a whole. And then when you're sitting in an organisation, what are the levers within that organisation to understand these lived experiences, but also to take action that's within your sphere of influence, really. So within the NHS, there is a national agenda around health inequalities, and NHS organisations have a duty to address and tackle health inequalities, which I think speaks particularly to this group, because we know from what Sheena has said and from a big body of evidence that there are some groups in society that experience extreme disadvantage, and that's kind of beyond even living in an area of deprivation. It's very extreme disadvantage. So things that are helping us within the NHS are agendas such as Core 20+5, which is the groups that live in the Core 20 most deprived areas, and then plus groups can be locally defined. So a lot of the groups that Sheena's touched on would fit within that Core 20+5 agenda, and then it's how we use that agenda to really affect change. So things that we are thinking about in that agenda are, how do we as an organisation take action on the wider determinants of health? What's our corporate social responsibility role? And thinking about access to healthcare, and how do we understand whether that's a problem for particular groups and whether there are differences across different groups. And then broader than that is the broader public health agenda, which is making is much more prominent now, I think, than ever in the NHS. So we've historically had things like the NHS long-term plan. Last year, the CQC changed its inspection framework. So there's a strong emphasis within our inspection around equity in access, experience and outcomes. You'll have all heard on the news about the Darzi report, which again recommended some shifts for the NHS. So a shift towards prevention, a shift towards healthcare being closer to where people live, and a move to digital. And then the government setting up and a health mission delivery board, which brings health into lots of different parts of government, which are all helpful things when we're trying to think about people with severe multiple disadvantage. I think we've got lots of levers, I guess, is my main point for that slide. I'm using the term inclusion health groups. So it's probably an NHS coined phrase, but we could equally talk about plus groups or groups with experiencing severe multiple disadvantage. So we've got a body now of evidence that certain groups experience these extreme forms of disadvantage, and we know that people might belong to more than one group, so they might have layering of experiences that cause them to have health inequalities. But what we also know is that those groups often share common experiences, which are often about the way we design and deliver services. So I think we've got a lot of reflection to do about why we behave in certain ways towards certain parts of our population and communities. So we know from qualitative research that people can experience discrimination and stigma. Often people have had adverse childhood experiences, and things like violence and experiences of trauma are not uncommon. Poverty tends to be a common denominator, and being invisible in health data sets. So you may have heard the phrase, if you're not counted, do you count? And I think that's often, unfortunately, quite true, that if we're not counting health inequalities and we're not looking at who might be facing them, how then are we taking action around them? So I think there's probably something to discuss this afternoon on how do we see people in data sets, and it's not all about numbers, but they do help us understand an issue. So we know that all those experiences can be overlapping, and then they lead to other things like insecure, inadequate housing, very poor access to healthcare, poor experience of public services, etc. And then I've put a little bit there about Core 20+5, because I think, again, it's that lever. We're being asked to address health inequalities through that framework. So let's think about how we use that for those groups. And then I just want to draw your attention to some work, and this again links back to how we use data. So at Northumbria Healthcare Trust, we're looking at how we embed health inequality metrics into routine data, so it becomes routine business for us always to be thinking about health inequalities and variation according to different metrics. It's relatively easy to include IMD, so indices of multiple deprivation, gender, rurality. My trust has a big rural and coastal aspect, so we do look at it through that lens. Little bit harder around ethnicity, but then when you come to groups that we've talked about earlier, it's really hard to see them in our data. But what we've done is we've got now a number of dashboards where we've got the inequality metrics that we can included. So this screenshot is from our outpatient Explorer dashboard, which uses Power BI, and it looks at all of our outpatient activity through an inequality lens. And because we've got a dashboard, it's really easy to go in and sort of ask questions of the data. And I was approached in the trust by a number of specialities in the organisation who maybe were coming across one or two individuals who were prisoners at HMP Northumberland, and they were concerned because they weren't accessing healthcare, and there were a number of was not brought to hospital appointments, particularly people on cancer pathways where the 2-week wait is quite important. So usually it would have been a case of spending quite a lot of time trying to find like this getting a sense of what this looked like. But because we've got the outpatient Explorer, we could just go in and automatically see a very high non-attendance rate for the prison population globally across a range of specialities. And because we had that at our fingertips, we've got some really helpful work now going on with the prison to really understand and unpick some of these challenges that the prison have and we have in getting people into healthcare. And it's an ongoing piece of work. It's a lot of quality improvement around it, but it was helped by having that information. And I would imagine that if we could look at our outpatient access through other lenses, for example, those other groups that we've highlighted, so people with homelessness experiences, drug and alcohol misuse, etc., we might see a similar non-attendance rate, but I can't do that because we don't code it and we don't collect it in the same way. So that is my point around sort of capturing people and then that leading to action. And then for the people who are in HMP Northumberland, as part of our quality improvement, we looked at some of the evidence base around why those people might be struggling to get to the healthcare that we've identified they need. And again, these things are always complex, but lots of reasons why. So security overrides the need for healthcare. So in HMP Northumberland, they're only allocated 6 escorted visits a day from the prison. It's a population of about 1,200 prisoners. So they only have 6 opportunities to take prisoners from HMP Northumberland. So if there's 8 appointments needed on that day, who goes and who doesn't? Prisoners don't find out they're going to an appointment until they're about to leave the prison because of security. And imagine if you found out you were just going to have an appointment 5 minutes before you had to leave. How have you prepared yourself? Have you had a shower before you're going to have an intimate procedure? So those prisoners often don't want to come, and that can be very convenient for the prison not to bring them. So those kind of reasons factor in. Also things like health literacy and stigma of being in an environment where everyone's watching you because you've got cuffs. So the evidence is really important, and the work that we do collaboratively with teams like Sheena's helps us to raise these issues to the forefront so we can factor them in when we're making judgments about where to take action. So it's just, again, another example of the evidence. There's been a really useful framework for inclusion health that was published last year. So it helps healthcare organisations look at how they can apply these principles to our planning and implementation of healthcare. So we've looked at those in our trust, and we actually did a dedicated session. Northumbria Healthcare Trust has a Health Inequalities Programme Board, which has representation from senior people in the organisation, but also local authority partners, academic partners. and primary care and voluntary sector. So we spent a session benchmarking ourselves against that framework, and we looked at where we felt we were doing relatively well. And again, that's quite subjective, but we made some judgments, and then what could we do more? And that's now informing our work over the coming 12 months about what we need to do to kind of reduce these inequalities for this group. And then I've just wanting to finish with sort of just reflecting on some of the other work that all feeds into this this agenda, really. So Sheena and Niamh mentioned that collaborative work. So we've been doing some work over the past couple of years with Newcastle University and partners to look at we started with presentations at ED, our emergency department, recognising that many of those presentations were for social reasons rather than health reasons. And then that led to looking at mapping the systems, which Stephen's going to talk more about. So that relationship between service and academia is really important and powerful, because it means that we can gather evidence about what's happening at a broader level than our own organisation, and garner new evidence about what works, etc. So I've mentioned the Health Inequality Programme Board in the August session, and following that we're doing some further work with business units in the Trust to look at what they're doing around inclusion health, and that can then inform annual planning. And also public health in our Trust is part of quality panels, so we sit on the quality panels internally that look at how we're doing against the CQC framework, and we can have that added inquiry with our services about particular groups. And it's changing, I think, the culture in the organisation to think about it's not just one size fits all. And if you've got, say, a good response rate from a patient survey, you might still have missed certain groups or certain populations. So we're very pushing that kind of approach, really. System approach, so it's about everybody doing their bit and us trying to work as cohesively together. And that could be things like shared training. So we've done shared training as part of the NIHR research on trauma-informed approaches. So, so that we're all aware of the kind of responses people are being given and how that affects whether they can access care or not. We've got a navigator pilot that we've implemented in the Trust, where we're working with particular pathways to contact people that are at higher risk of non-attendance before an appointment, to understand if there are any barriers, and then to try and address those barriers either at an individual level or at a trust level. And that's got external academic evaluation through Newcastle as well. We've got World Cafe events, and that's bringing trusted community partners into a shared space where we can have conversations about barriers and joint working, etc. And we know for a fact that often those trusted community partners are more likely to be reaching the groups than we are as the NHS. So it's really important that we work with those partners. And I think, again, that's an ongoing piece of work that needs to get stronger. I've mentioned about HMP Northumberland, and then as a result of some of this work, we've got a range of quality improvement programmes. So we're doing a lot of work around healthcare travel. At Northumbria, travel is a big barrier because of affordability and poverty, but also because we're a very rural geography and there aren't many buses in certain parts of the patch. We've worked with Children North East on poverty proofing pilots, and we're hoping to become a poverty proofing pilot. And that's about healthcare not being blind to the wider determinants of health, and thinking about what we're asking of patients might exacerbate their experiences of poverty. So how can we do things differently? And also, how can we use our influence as a corporate entity to create access to things like employment, work experience, how we procure services, etc. So a lot of work going on around that. Digital inclusion is really a key area that all the NHS needs to and is working on. And again, we've got work to do on that, but recognising that not everybody will have access to the way that we communicate with them. So we need to make sure that there's lots of choices around how we communicate, and similarly health literacy. Then in our trust, we've got a public health learning and development offer. So we've made a commitment that will include inclusion health within our awareness raising and workforce development, so that people recognise that there are certain groups that have particularly difficult experiences, and how we can change accordingly. We've got patient and staff experience work going on, and we've got a patient charter and a patient panel that are holding us to account around the principles that we apply within healthcare, and that's really important. And if we reflect back on the stigma, etc., that people experience, it's really important that those people are involved in the way that we plan and deliver and organise healthcare. Our trust's got a new clinical strategy. Health inequalities are right in there, as are prevention, as are recognising the wider determinants of health. So that strategic architecture to then make change is being built, and then it's about how do we make sure that we deliver the things that we want to deliver. I've mentioned the groups in the data. I've put very challenging in brackets. I'm hoping this afternoon might be helpful around that. And I've said that more needs to be done, and mentioned the NHS framework, because it's a good way of us capturing where we're at, but what more we do need to do. And I think that's the end of my slides, and I've put my email address there. If anyone wants to make contact or discuss anything, very welcome to. Thank you. I hope I haven't overran. Sorry.
Yeah, thanks very much, Jill. That was great. Really great. Thank you. So in the interest of time, we'll just go straight on. Next is Peter Miller from Horizons Northeast. Again, just a perspective from voluntary sector organisation. Peter, do you want to just introduce yourself and over to you? You're on mute, Peter, I think.
Thank you, Sheena. One day we'll all be able to do one of these things where somebody forgets to take themselves off mute, and then. So thank you, Sheena. I'm Peter Miller. For those of you who haven't met me before, I'm the Managing Director of Horizons Northeast. We're a supported accommodation provider across South East Northumberland. And it was really actually interesting to look at all that stuff that was on the slides there for Jill, because so much of that translates through into what we see, and the fact that it's kind of up there as things that are being identified as priorities, and people recognise the benefit that comes from sort of looking more deeply at those kind of issues. It's really encouraging for me to see that. As I say, there's a lot of similarity. So our clients, we've got about 80 clients in service at any one time, probably about 300 throughout the year that actually access our service, but probably about maybe 1,000 that apply to join our service in a year. And there are definitely common themes across a lot of the people that apply to us. I mean, obviously they're all facing homelessness, but multiple and severe disadvantage. And I think, all those things that we talked about in those slides, Jill, absolutely come through in the clients that try to access our service. And when we think about sort of the multiple disadvantage, for me, what is always really quite shocking is not just the scope of disadvantage and inequality, but actually the relentless nature of the exposure, the continual, when people just got multiple experiences of the same kind of exclusion over and over and over again. People who just simply don't fit into systems, they don't fit into services, and feel forgotten, and maybe to an extent are forgotten. And I don't think there is a silver bullet, but I do absolutely think that we can make a difference. And I think what it is about having the energy to match the disadvantage and inequality with the same level of energy about making sure that we make some inroads into challenging those things and actually being determined to improve them for people. And I think that once we start thinking like that, it gains momentum and it gains traction, and we can make a difference. when we look at, essentially what we're asking here, we're asking, what kind of factors lead to people being excluded from services, and from accessing the services and systems. And I think, one of it's about belief systems, about people being surrounded by people who have an experience of all those things they identified. So, experience of sort of local authority services, healthcare services, etc. The families that people are brought up in, and the continuation throughout a family of certain kind of beliefs and expectations, and also motivation or lack of motivation to sort of access a service. So some of the things that we would access services, and we would automatically have things in our lives that would just stop us from thinking about not attending a doctor's appointment or whatever. So, whether you've got children, whether you think, oh my God, who would do my job if anything happened, or I need all these things that motivate us to kind of want to be well. People don't all have those motivations, and we see regularly this idea that people actually, they're quite the opposite, and you think, well, why would I bother? Who is bothered? And so therefore people don't necessarily access the services. And I think what we've identified is that when you involve people in sharing their experience, their lived experience, it's an extremely powerful experience for those people that have up to that point often never been heard, never been really listened to. And there's a couple of kind of key things that I think we've learned from our experience of being involved with academic partners to access these hard to reach groups. And Jill, as you say, quite often recognise that some community partners do have better access to these groups of people than maybe the NHS would have. And there are things, so people can quite often kind of come to us to gain like access, if you like, to information from the people that access our services. And from that, we've gained, there's a lot of things that have kind of gone well, and things that we would sort of share as our examples of best practice. One of the things is really, when we're looking at including people in research, it's not being too prescriptive about how that research might involve people. So actually involve people in the process of asking them how they want to be involved, if that makes sense. So, let's not assume that everybody doesn't want to put something in writing, or let's not assume that everybody does want to do something on a one-to-one, or that there's some common kind of assumptions that we can make. And we found that people will share experiences in different ways if they're given a broader range of opportunities to be able to do that. And one of the things as well is making sure that we get people's buy-in to the overall project. So if someone actually understands what they're contributing towards, understands that they're opening themselves up, sharing really difficult, this isn't a story, this is their life, this is an experience. And if they're, and they're going to, in a lot of cases, suffer detriment from sharing that experience, and they have to feel that it's worth it. They have to feel that the price that they are going to pay is going to be worth the, worth it in the end. So just to really include people in the kind of purpose of the research right from the start, I think really does help people to open up. So again, the other thing as well is thinking about where people are and the timing of where people are in their own journeys, and how that's going to influence the kind of message that you get from the discussions that you have. Pre-contemplation, contemplation, maintenance. So is it something that they've just experienced? Is it something that they've kind of created a bit of a narrative over? Something that they've started to address? That really does affect the input that they give, and how that, and it really does need to be taken in a contextual sense. Otherwise, I think it can probably skew. You could speak to the same person about something, and then speak to them about it 6 months later and get really quite a different picture. And a kind of an example of that I thought was a really powerful example was we interviewed someone a couple of months ago who had just very recently had acid thrown in his face, and it completely underrepresented that in the meeting. It was like, oh, it's okay, oh, it's fine, it wasn't a problem. It was a serious problem, it was a significant problem, it was a life-changing problem. And you have to ask why would somebody say it like that? And sometimes we don't always appreciate what is at stake for that person when they're answering questions or giving responses to research, and actually believing that they think they know what you want to hear and what you what you want to hear that's going to give them the best outcome. So that is something that you need to kind of be thinking one step ahead of why might somebody give that answer. We've used lots of different a variety of different methods of kind of gathering information from people, and all of them have shown success in different ways and challenges in other ways. So group discussions has been a really powerful opportunity to share experiences for our clients. And again, we've found that using existing social group structures overcomes that barrier of people kind of weighing each other up, and so that we've got, for example, a fishing group. So we quite often just transport the people from the fishing group to a research process, because they already know who each other, they know who they are, the dynamics are already established, they kind of just get on with whatever it is they're being asked. They don't have to suss each other out. So that use of sort of existing social structures has been really helpful. And also, and I'll speak from personal experience on this, is the idea of allowing the group to be led from within. So as professionals, I think when we're doing group discussions, you're kind of champing at the bit to move things into a direction that you feel that you want the conversation to go, or whatever, and avoiding really sort of cringy moments of things not quite panning out as you want them to go. But actually, if you can really resist that temptation, and it's hard, if you resist that temptation because they expect you to lead it, if you don't lead, then suddenly the dynamics change and people will share experiences that they probably wouldn't have shared if it had been led by a professional facilitator. And one of the things that we've really noticed is just how people will bounce off each other's experience. It takes one person to say something, and then suddenly it triggers a confidence in other people to share similar, stories. So that idea of using group discussions, but a combination of being led by the, in our case, the clients or by a facilitator. Some people want to share their experience on paper. We've had some really powerful testimonials that have come through where people have wanted to tell a story, but they just want to tell it in words. Some really unbelievably powerful experiences that we've had, whether that be through a questionnaire, whether it be just through journaling of their experience. Sometimes it's through sharing with you a professional report that's been written. People have quite often said to us, this was written about me. We had an example where somebody had been a victim of very serious sexual offences that had gone on in a school, and there had been a consultant psychologist had written a report about their experiences, and he really wanted us to read that report because he felt that told a story about him. So sometimes just asking if there are things that people want to share with you that are, might not think otherwise of sharing. One of the things that I've found the most very unexpected as a way of people sharing experience is actually through film. At the moment, we're working with a company called Candle and Bell, who have done quite a few sort of local community-based films. And again, these sort of preconceptions that you have. So for me, this idea that somebody's sitting with lights on them, with the camera, a whole range of cameras, you think, oh, it's going to be intimidating, it's going to be too much, it's going to make them close up. So you're there trying to sort of compensate for that, keeping them chatting. And what it had was a completely empowering impact. I don't know if it was the neutrality of the camera, the lack of someone of eye contact, or what it was, but people that we've had in service for many, many years that have opened up to us in really very genuine ways, have shared experiences that we knew nothing about once a camera was introduced, and that was a real learning thing for us. And one of the things that Jill, you put down as being a strength was that the language. I think you can't overemphasize that the idea of like making sure that language is not just inclusive, but also that we're not using language that already has preconceived like it's a kind of loaded language. So we're talking at the inequalities conference with a GP, and the use of the word chronic. So, you know, a pretty straightforward word, but the connotations that can have. So some of our clients, if they read the word chronic, they would think, oh, well, chronic, oh, so I'm not going to bother then, or oh, it's too late, or I'm beyond fixing, or whatever it might be. And then their actions follow on from their interpretation of that language. And I think as well, for a lot of clients, for us, that idea of engaging them within health services, it can be done, but it's so important that if all the groundwork goes into getting somebody to open a letter or open a conversation or take a call, you know, just take a call if someone's ringing them, then it's really important that if that happens and we get to that point, then what we say on that call or what we say in that letter or how we say it in that letter, it can't be a flippant, like we've always done it this way, we've always used that phrase, we've never bothered ringing people up. So that idea of kind of the people that are likely to not attend, having interventions that kind of make it less likely that they won't attend is great, because it is the thinking outside the box that's going to really make a difference. So I guess the last thing really for me was just about the ethical considerations of involving people in research. It's kind of, you know, recognizing how they might feel afterwards. So we've done some work with the Health Foundation. Was one particular client was interviewed by the chief executive of the Health Foundation, was so empowered by that experience. It was a fabulous experience for him to be heard in that way. But a few weeks later, it was really quite a damaging, like, aftermath. So it was overall positive, I'm sure, but being mindful of the fact that who's going to follow it up? If as a researcher, it's probably not your job, but somebody needs to be there to actually make that call to check in with that person. If someone's sharing something really life-changing an experience, somebody needs to be there to check that they're all right afterwards. And really about the whole process of validating someone's emotional response to a situation is okay, but it's actually quite dangerous to validate somebody's a narrative that somebody might have created. So as a researcher, somebody might be working through a narrative which might not be an accurate narrative, it might not be a positive and helpful one, but you are as a research, when you're doing the research, you as that person sitting in front of them have, you know, an extreme power. They just think that whatever you say will be absolute gospel. So if you appear to sort of validate and potentially inaccurate narrative or a damaging narrative, then again, that's a bit of a responsibility that you have to sort of be aware of. And really, I just sort of finish on the idea that the value of being heard. We spend every day talking to people who have spent a lifetime being marginalized, excluded, not heard. And the counter side of that is that when they are heard, then the experience of that and what they have to bring to a process or the shaping of a policy is, you know, gold dust. It's so much more than you would ever expect. We never cease to be amazed by what people bring when they're given the opportunity in the right environment and in the right way to contribute their experiences to development services and practices. So that's our experience. We could talk forever on it, but definitely say it is absolutely a worthwhile process to involve people with lived experience, but doing it right and being mindful of the responsibilities that come with it is so important. That's it for me.
Thanks, Peter. Thank you so much. That's really helpful and really complements the things that Jill was sharing before. So thank you for that.
Thank you.
We've just got a couple more brief presentations. One next from Stephen. Stephen Thurkel is my colleague from Newcastle, a research associate, and Stephen will share some findings from one of the projects that Jill just mentioned before, and then followed by Neha. And then we'll have a couple of questions. So keep those coming if you haven't already shared any comments and questions. But over to you, Stephen.
Thank you, Sheena, and also thanks to Peter. I thought that was an excellent speech presentation, and I was scribbling down a lot of notes. I've managed to fill 2 pages. Just to hold myself to account, I'm going to pay particular attention to the language I use during my short presentation here today, just to try to break down some of those barriers, as you were saying. So hi everyone, I'm Stephen. I'm just here to talk a little bit about the work that we've done with a few partners that are in this room actually, but I'll just very quickly get into it. So our study was sort of investigating support for people experiencing homelessness, as well as trying to identify unmet needs through a variety. I hope you can see my screen, by the way. But it all began with, thank you. It all began with multiple partners. Some, like I've said, are in this room today. Some are not, but just a few sort of logos of the partners that were involved. And the need identified by our partnership was to identify that support, like I was saying, using trauma-informed approaches to help people navigate the complex systems that we have, such as the healthcare system or other support systems as well. But the goal of this was to improve the short and long-term social and health, including the mental health outcomes for people experiencing homelessness in Northumberland and North Tyneside. So focusing on that rural and coastal part that Jill so kindly introduced before. And the research goal, so rural and coastal areas overall are much less understood and under-researched, but people experiencing homelessness, and so this is very much where it started, people experiencing homelessness still frequently attend emergency care services in urban areas, but they also do in non-urban areas such as rural and coastal areas. And our aim was to understand and address some of the challenges that people experiencing homelessness in these areas face to hopefully inform holistic support. So just to very quickly touch on the method before I take you through the findings. So like Jill mentioned before, we looked at hospital data of emergency records. And that was the first part. And then to follow that up, so all of these are sort of interconnected, and to follow that up and to dive a little bit deeper, we wanted to speak to people who had experiences of homelessness, but also people who were providing support to these people in various services, from emergency care, ambulance, law enforcement, to housing and so on. But then we also wanted to understand a little bit more about, I suppose, why services or how services, how connected services were. And this led to a mapping of about 60 services, which I'll touch on in a later slide. And then we took all of this research that we did up to this point to a workshop involving almost 70 professionals, I think. And some people may remember this. It was held in Cramlington, and we co-produced some recommendations at this workshop, which we then disseminated, and which we'd be happy to disseminate at the end of this workshop as well. And then to sort of close that piece of research off, we did a pilot of trauma-informed training across the sector, so with multiple services, with a few service professionals working from those services. And so with the hospital data, we found that there were approximately 258 homeless people who had made 567 visits to emergency care, and this includes the emergency department, it includes the minor injury unit, and then also there is another one, but I can't remember what that is right now, the walk-in clinics. But there are, and then also what we found from this data, that there were frequent repeat attendance of the people that we were studying. And the most common reasons to attend ED were related to substance use, mental health, but also social issues. And something interesting was that there were multiple or co-occurring, so which just means that there were many taking place at once, or many people on presentation were receiving a few diagnoses, so more than one. And to do this was very difficult to identify these people. And so we had to use something called a proxy, which is just a different way to identify a group of people. And that proxy was just to use the no fixed abode. And like Jill had mentioned earlier, it's very difficult to capture groups of people within sort of these data sets, which I'll touch on at the end of this slide as well before I finish. And so just to understand a bit more about why people were accessing emergency care in Northumberland, North Tyneside, we had the interviews and focus groups with people experiencing homelessness, as well as people providing the services and working in the services. And a few things that we found. So just in general, in rural and coastal areas, there are just general accessibility challenges. Northumberland, for instance, is a huge geographical area, and there are services spread out across that area. And I can remember speaking to one individual who had to travel all the way from Berwick and down to the hospital, which is quite, I think, a couple of hours away. But this individual had to travel by bus and overnight just to make that trip to access help. Then also inflexible service criteria. So people being turned away from accessing help because potentially their symptoms or their situation isn't as worse as or bad as it would be, that would enable them to access the support. So they're being turned away to get worse before that they can get better. And then people prioritizing needs. And so people being unable to manage their multiple needs, multiple complex needs, because they've got other more pressing needs, such as finding somewhere safe to sleep at night, or finding somewhere warm, coming into winter now, but also food and other things that are pressing. And then touching on the fragmented support in rural and coastal settings. And what this means is that support perhaps being a bit disconnected. And this sort of contributes to the geographical distance, but also, I suppose, services not collaborating or communicating as well as perhaps they could be with people who do have multiple complex needs. And then we moved on to mapping the connectedness of services. And we spoke to around 24 service providers to build a map of 60 services that were within this sort of organizational network of services. And the sort of image that you can see on the screen there is essentially these different types of services, and the different shapes are basically the different types of services. So it could be housing, it could be health, or another form of support. And what you can make from this map is that there are quite a few services, but there are also services that are sort of isolated and are on the outside of the network, perhaps not connected as well as they could be as some of the more core services that are on the inside. And what we understand from this sort of piece of research was that perhaps the network of organisational support in Northumberland, North Tyneside is a little bit disconnected. And then moving on to the workshop that we held in Cramlington with approximately 70 services, if I'm remembering correctly. We collaborated and so we presented all of our research up to this point. So the hospital data, the interviews and focus groups, as well as the mapping study. And we shared this data with multiple people. And there were also people with lived experience at this workshop as well. We managed to come up with 7 recommendations that you can see there, such as long-term funding and coordination connectivity. And many of these are meeting those findings that came out of the earlier research, but also things that were brought quite new to the workshop as well. And from this, we moved on to a pilot study of a trauma or an evaluation of trauma-informed care training to explore the integration of trauma-informed care within services across different, across the sector that support people experiencing homelessness in these rural and coastal areas. And some of the learnings from that training were that compassionate communication, for example. And so it's already been mentioned, but language and moving away from saying things like what's wrong with you, but what's happened to you, and understanding a bit more about the story. But then also being transparent and letting people know what you're doing, why, and what's next, so that people have a bit more control over their care, or at least being in the know and being less anxious. As well as having resources that are accessible for staff. So creating strategies that colleagues can quickly use in their day-to-day tools. So things that can be looked at and can be understood in just a couple of minutes while you do have that space with a service user or a client, because often time is quite short. And then also shadowing other colleagues across the sector in different services, just to understand what that looks like and how support is delivered in another service, which could then help both services, I suppose, work better together to deliver the care for the individual accessing the support. And then ongoing learning and well-being. So making sure that staff are prioritised and their well-being is prioritised, but then building resilience in staffing. So going back to the second point around tools and techniques, but then also understanding the triggers in ourselves as well to better support service users and clients. And so just onto my final slide then, and I hope I haven't rushed through that too quickly. So just to help inform, I suppose, the discussions that we're going to have after the break, some of the gaps that we sort of observed during our research were, of course, perhaps the service coordination not being as well connected as it could be, and then also there being limited access in rural and coastal areas, as well as transport barriers and the like. And then the geographic isolation, like I said, the transport barriers, but then also having insufficient mental health and trauma-informed support. So having a few options available to people, especially if some people are excluded from services and there's just nowhere else to go. The hidden nature of rural homelessness. So this is what Jill touched on, and what we saw in our hospital data was that there are some people, large groups of people that we just weren't able to capture. And then opportunities to develop mobile and outreach services, and then having those multi-agency networks to implement integrated trauma-informed approaches within those services, and then also to create local service hubs with co-located support, so having individuals from multiple services at one place where people can access and get the support that they need. So that's everything from me, and I'm going to stop there, and I think I'm going to hand you on to Neha now.
Yep. Thanks, Stephen.
Thanks so much, Stephen. It's quite interesting that that's been a fascinating presentation, and it's quite fascinating. What's really interesting is that a lot of those findings are reflected into the presentation that I'm going to be delivering now, which is about improving oral health and related health behaviours of people living with severe and multiple disadvantage in England. And when I speak of related health behaviours, I'm speaking of tobacco, diet, and alcohol and substance use. So in addition to what Sheena had mentioned in one of her earlier, in one of the presentations that was earlier today, is that massive role that wider determinants play in physical and mental health outcomes in people experiencing severe and multiple disadvantage. But if you look more closely, within this population, it's very easy to fall into a perpetual cycle of disadvantage with poor health outcomes. So even if we start somewhere at oral health, which has been historically quite easy to wipe off and not think about in terms of priorities. But the thing is, with oral health, with poor oral health, there can be a perpetual cycle which starts with functional limitations, pain, chronic inflammations, which can go on to physical ill health, poor nutrition, low self-esteem and stigma, social isolation, all of which has been evidenced in the research, which then in longer term leads to obviously costs to health and social care, poor employability and education, which then eventually leads to poor health behaviors, which again relates back into oral health. So I suppose with that thought in mind, we've been thinking about the aim of this research project, and we really wanted to identify interventions that are effective but also sustainable in improving oral health and these related health behaviors in people experiencing severe and multiple disadvantage. So to sort of think about this aim, we wanted to answer the question into what truly works. So what are the effective interventions, but also look into how do they work? So looking into implementation, sustainability, as well as acceptability and access to these interventions by people. And we just a bit of background on this project. We did deliver this. We conducted this project quite collaboratively in close working with people with lived experience of SMD. We worked closely by the experts by experience network from Fulfilling Lives in Newcastle Gateshead at that time. We also worked closely with practice and policy stakeholders in Public Health England, now OHID, public health teams and local councils and practitioners in NHS England and national charities. We did a systematic review. I'll not go into a lot of details, but we did a systematic review to look into the effectiveness of interventions. And we did a qualitative study as well to look into implementation of interventions and access to support to sort of identify gaps and opportunities. So in terms of looking at what interventions really have been effective across alcohol use, drug use, and combined drug and alcohol use, we found from a systematic review that behavioral therapy, which sort of involves housing and employment, but is subjected to alcohol abstinence or is subjected to substance use abstinence, has been effective across alcohol use, drug use, or the combined drug and alcohol use. But in addition, we also found that housing first models, which I'm sure all of you know about, but is integrating housing with other services, was useful and effective for alcohol use. Intensive mental health programs and intensive therapies have been useful for drug use and combined drug and alcohol use. When we did the qualitative study, we spoke with people in local authorities, healthcare providers, and third sector across 3 different regions in England. But we also spoke with people experiencing SMD. And what we really found about these interventions is that there are a range of factors that really affect how they are implemented, but it also affects how they're accessed by people experiencing SMD and what barriers and challenges there have been in engagement. To give a brief overview, and again, like I said, a lot of these findings sort of reflect with what Stephen's covered in the presentation before, is that, of course, our study found that there's a need for integrated services that sort of work well together. Inclusive services which are tailored to the needs of people experiencing SMD were found to be a prerequisite for improving access to interventions. So sort of working with them to identify the locations of these services, the duration of appointments, the actual booking, the actual appointment times. All of these are very important in determining how sustainable these services can be. But also looking at physical space and trying to make these physical spaces as less stigmatizing as possible for the people is very, very important. We also identified the need for training for healthcare providers to sort of understand these wider determinants while treating people with SMD, and sort of also understanding how better to make these services as less stigmatizing as possible. And then which sort of links into the fact that interpersonal factors or the relationships between service providers and service users are very, very important in how these services are delivered. Empathy or understanding amongst service providers was found to be useful in reducing that stigma and that trauma eventually. Individual factors like wider determinants and disadvantages, as Sheena spoke before, were very important, and this included motivation and priority for receiving healthcare, as well as fear and stigma. So these psychosocial factors were important, and training the healthcare providers were looked upon as factors that could be useful in making these services more accessible and sort of improve engagement of these services. Speaking about these wider disadvantages, we spoke to someone experiencing SMD, and they said that they sort of demonstrated this by saying, you'd eat your sweet stuff, and then the years of taking drugs and the chaos, you didn't attend appointments. I don't think many of us started with bad teeth. I think it was just the lifestyle we led and the predicaments we were in that impacted on our health and teeth. Service providers also reiterated this by saying that there's many competing issues that is presented from homeless or substance user. Their needs are complex, and sometimes it's about will they still be alive the following day? And sometimes their dental health care is not a priority. So sort of it's very important when thinking about oral health and these related health behaviors to sort of really think about the role of wider determinants and how they are prioritized by people experiencing SMD. From these findings, sort of also thinking about where do we go next and what next, and sort of to help with the discussions we are having after the break. But I suppose in terms of gaps and opportunities, while we did that evidence review and we found a few studies looking into the effectiveness of these interventions, I think what really happened is that the studies that we found on what works for substance use for over a short period of time, and there was a high dropout rates, sort of highlighting the need for while we know about the implementation of these services, there's been some evidence from the studies that Stephen has done and from the studies that I'm just speaking about. Sort of thinking about oral health interventions and thinking about diet interventions and specifically about the effectiveness of those interventions might be useful when we try and translate these findings into actual practice and policy. Of course, the studies that we spoke about in the evidence review were primarily based from USA, and we don't have a lot of contextual information on these studies from the UK. It might also be useful to think about cost effectiveness of intervention, especially if we are thinking about translating some of these findings into actual practice and policy. So getting that element of cost effectiveness might also be quite useful. And of course, going by what has been discussed so far, all of these studies, we do need to do better in improving the inclusion in these studies by people with lived experience, and not just in a tokenistic way, but actually having them on board and co-producing some of these studies, which my colleague Emma is doing a lot of work on co-producing interventions with people experiencing SMD, but sort of getting that in. I'll stop here just to say that the research brief from both Stephen's study and this study are available on Fuse's website, along with these visuals that we had developed with an organization called as More Than Minutes. They're all available online, and I've put the link in the chat box. I'll stop here and hand over to Sheena now.
Great. Thanks very much, Neha. That was really good. Thank you. And thank you for all of those presentations. I think if anything, it sort of really mutually kind of reinforced a number of the issues that really we've been talking about from different practice perspectives, but also actually the evidence that sort of lies behind it as well. Emma's just put in the chat, so if there are any questions at all or comments, we're slightly over time, and we do want to just make sure everyone has 5 or 10 minutes for a quick break. But are there any comments anybody wants to share? Just 1 or 2 comments at the moment, or questions? Nothing I can see.
Thank you, Sheena. If I have the floor. Thank you so much for the presentation, Neha. I really enjoyed it. But thinking, when you did your literature review, how was the effectiveness of interventions measured? Was it in relation to the health outcomes, or were there some, and you mentioned obviously that there's lack of evidence around cost effectiveness. So if you could just highlight how the effectiveness of these interventions were measured, I'll be grateful.
Thank you for that question. Yes, I'll quickly add one point, and I'll see if Deepthi, who's on the call with us, if she's got anything to add. She led the effectiveness review, or Sheena, if you have anything.
Yeah, I'll just come in on that. Yeah, so it was on the effectiveness was in terms of the health outcomes, and the results that Neha has presented here was in terms of health outcomes defined as substance use, really, and related to substance use, and both drugs and alcohol use as reported in the study. So yeah, it was health-related outcomes.
Thank you so much. And just a follow-up question. So I saw the more like an ecological map where you talk about interventions being focused at the individual level or the community level or at the national level and policy related level. Considering that cost will be a priority for a policy decision maker, do you have any insight or did you find any evidence from literature where there are interventions probably at one level of concentration that could have a reinforcing positive effect on all the other levels? That way the policymaker is able to use one bird to kill one stone to kill about two or three birds at the same time.
Yeah, so I think this Paul, is that coming in response to that or a different point?
No, I'll leave that one to you. I think you're better.
Right. Okay. No, it was, I think probably two things to say on that. I think you're saying where the one intervention might have multiple positive outcomes. And I guess the one example that came out was this issue of where some interventions actually integrate a number of those issues that are at play. So the example that Neha gave was of housing-based intervention. So that was one where actually multiple different needs could be addressed. At a policy level, from the review, we didn't really find any sort of evidence that came out of the systematic review, but from other pieces of work, we know that obviously more policy level interventions can have wider effects, on at a population level. But yeah, completely hear your point about sort of something that can act more upstream, I suppose, in terms of addressing multiple needs. But thank you for that, Eunice. Paul.
You definitely did a better job than I would have done with that, Sheena. No, I was just going to say, just on Braca and Neha's presentation, it really made me think about how big an issue oral health is, and it's I get constant feedback from support staff about the difficulties in getting people to engage in dental care, and it's probably more so than virtually any other type of health related conditions, to the extent where we've had recent examples of people find it less anxiety inducing to restart a cocaine addiction to try and treat the pain than to get a dentist. Now there's obviously multiple factors, and I'll not go into all of them, but it really did, it focused my mind on how important it is and how much we actually see it every day, but don't quite register it with the same degree of priority that we would the other health concerns. And I just wanted feedback.
Thank you. Jill?
I guess it was just reflecting on that, and I think access to dental health care is hard for the general population right now. So you can multiply that for groups that experience barriers for lots of other reasons. And I think that, I guess, thinking about the evidence, I think it's prevention, and a lot of the behaviours are rooted in the wider determinants of health. So when we talk about health behaviours, those behaviours have got very clear links to things like poverty, things like poor housing, etc. And it's always trying to make that connection, isn't it? And like you said, Peter, even thinking about the language that we use, because I know there's been a lot of work done by organisations like Frameworks UK, where if we sort of the general public, like maybe 4 years ago, would have a view that people's behaviours were very personal, and it was kind of rooted in their own actions. And there has been a movement. The last survey they did in 2004, we're becoming more aware as a public of actually behaviours are very linked and located in the wider determinants. So I think for me, the strong evidence is around poverty, and that as a common denominator. And if we think about those things, and if we there is a big strong evidence about addressing the wider determinants of health. So any policy or structural things that do that inevitably will hopefully reduce the amount of people with severe multiple disadvantage.
Yeah, it's going really upstream, isn't it? Thank you, Jill.
Yeah.
Great, thank you. That's been, I think, we should have a break so that everyone can stretch their legs a bit. So we've got a little bit over time, but I think we hopefully still have sufficient time for discussion. It's 3:20, or just after 3:20. Can we come back to start just before 3:30? I think we'll kick off our interaction session at 3:30. So if that's okay, you can stay on, you can turn your camera off, mute, and then join back at 3:30, please. We'd love to have you as part of the discussion.
Should we have a start now? I don't know if everyone's back.
I'm fine.
Yeah. Okay, so we're just a minute left to 3:30.
People are just coming back, I think.
Okay. So while they're doing that, just to say that this illustration that's on your screen right now, it's a word cloud based on the answers you'd made while registering into what areas in public health would benefit from further research. And I think it was like a good starting point for us into the interactive session that we're having now. We had originally scheduled it to be 40 minutes. We'll try and see if we can wrap it up in 30 minutes so that people can end this meeting well in time. Sort of just taking a minute to highlight what the goal of the interactive session here is. So we're really looking to identify areas of action where research can help address this knowledge gap and build evidence to inform practice. It would be really, really nice if you could think about things we've spoken about so far from the presentations, but from your own experience as well, and sort of look into barriers and challenges that can sort of improve the physical, mental, and oral health of people living with severe and multiple disadvantages. We have some questions to go to guide this discussion. So sort of really looking into the barriers to improving the health of people experiencing SMD, opportunities in the system, sort of reflecting into what Jill had also mentioned in her presentation for making a positive change, but also sort of looking at maybe two main recommendations for improving inclusion and involvement of people, and sort of two action points for practice or policy, which could help address these issues that we've identified before and where research or better evidence can sort of help. So sort of really think about who, what, and where to help identify these actions and research priorities. So we're using breakout rooms, and there'll be a facilitator in each room who'll be using Padlet, and they will be happy to facilitate all of this and put these points onto Padlet, which we'll be able to see as a team, and then we can just come back and reflect on those.
Okay.
Is everyone back? Yeah. Okay.
Looks like it. I think we're all coming back.
I don't think we lost anyone. It's the same number of people that we had before you clicked in, Neha. So I think you're good to go.
Perfect. I'll leave this on the screen for everyone to see the main action points and the other discussions.
Great. Thank you all so much. There's lots of really nice discussions, and hope you've had some good things. There's lots of points up here, and so we thought we'd sort of end with kind of action points from each of the groups. So can we just go around the groups, and if the person facilitating can just feedback very, very briefly what maybe just one or two maximum brief points. So can we start with room 1? Now, was that the room that I was forgetting the numbers of the room?
That was Peter's room.
Yes, Peter. I thought so.
But
yeah.
I think the easiest one to sort of, for us to sort of communicate was this idea of like health literacy, and the idea of just making sure that we are actually getting messages across, being much better at communicating in a way that speaks to the person that is receiving the information, and not using overly complex terminology, and also avoiding the idea of mixing too many figures with sort of written information that can be quite overwhelming. So that was one of the things that came across from our group as an action, a simple sort of cost-free, really neutral action that could make a really big difference.
Yeah, great. Thanks, Peter. So room Oh, there's things flying around in the chat. So yeah,
I think
Paul,
room
do you
two,
want?
aren't they?
Yeah,
Yeah, we came up with a very similar point in regards to the language, and I think we specifically touched on, right to remain and the language barriers, and then you can, in the worst case scenario, you can make things worse with sending someone an official looking letter, inviting them to something, and you've got no way of interpreting it, or anyone you can trust to interpret it. You're potentially making things worse in essence. I know it's a very general point, but improved joint working, not just with statutory services and voluntary and private. We talked about some of the things that have gone with, like the use of Frontline in Northumberland, and better communication between the different authorities, or what's actually working well, and replicating and building on it on other local authorities.
great. Thank you. Thank you. Abisola?
Hi, yes. So we had lots of interesting points. I guess one that was the importance of meaningful signposting. And that was in relation to, for example, diets and signposting, like, for example, young mothers to where they can get nutritious food, and not just like food banks where they would get tinned and, dry food. And another point that I thought was really important was housing first, like the housing first model, and how that has good evidence to support. But why are we not using these sort of like models? And the idea that if you have good housing, you are likely to have a good diet. So yeah, those were some important points, action
Thank you.
points.
Thanks, Abisola. That's great. And then room four, I think Jill or Leslie.
Hi. So our group again had quite a full discussion, but I think key barriers were people's lives are not often simple, and they can have complexity, but services expect the person to fit into the service-sized box. So there's something about the needs of the person not then being met by the way the service is designed. And we use the word complex, so people can have complex lives, but equally services are very complex, and systems for accessing health and care and support is difficult to navigate. So that was a barrier we felt in terms of health outcomes, because health outcomes will be met in a multiple myriad of ways, and that's not just one thing. So that was something that came out. And then the cultural competence and the need for services to be culturally competent when working with people with huge diversity in experiences. Often people might come from different places across the globe. And have we got the cultural competence to recognise and engage with people in different ways? So that they were the kind of two things that could be barriers, but equally could be opportunities to think about improving health. And then there was something around how often the resources flow more into kind of big services and big organisations like the NHS, like local authorities, but sometimes those people with SMD they'll be more held, and the glue will be within smaller organisations and voluntary, and the resource perhaps doesn't match that. So the resource not matching the need. And an opportunity might be for research to demonstrate that actually resourcing differently is probably very cost effective.
Great, thank you, Jill. That's been really helpful. Is that all the groups? Have we covered everyone?
That's everyone, Sheena.
Great, thank you all. I think there's been lots of links actually across. I don't know, Jill or Peter, are there any final do you have any final thoughts you want to share? And then I'll just quickly summarize. Is there anything you want to share?
All I would say, just the last thing that Jill's just said there about research into, distribution of things things across, not necessarily the idea that the NHS might not be the best use of the fund, not suggesting that, but in basically this idea that it's not necessarily about money. I think people can get hung up that there needs to be extra funds, but actually just looking at things and saying, forget about the financial side. Within the constraints that we've got, are we doing things the best way we can? Are we communicating in the most effective way? Are we including people in the best way? And actually, are we getting the best outcomes from what we've got? And I think in almost all cases, there's better ways of doing things that are really simple. And we talked in our group about very often when you listen to people's lived experience and they're able to talk about the detail of things, it's a small detail. And this always amazes me, is that when people's lives are turned upside down, it's not necessarily over something major. It's a minor thing that they didn't have the coping mechanisms or the support network to be able, or the service to be able to access to help them, and then things just spiral from there. So can we do things better with what we've got, I guess?
Thanks, Peter.
And I think there's something in our group and generally around, there's a lot of evidence and a lot of research recommendations. How do we embed them into practice? So there's how do we translate that knowledge that you've shared so eloquently, Peter, into the way that we work and do things?
Yeah. Great, thank you. That's been really helpful, and I think that last session in particular, actually, because we've been able to draw on the collective expertise. I suppose we've all come here today because we have some interest. We're working in these areas, and it's been really great to share that actually and bring that together. I've just seen Ange there. Hi, Ange. We started this work together after 2017, I think. So nice to see you. And I think just one of the last things, actually, talking there about those kind of solutions, really, sort of where I think a lot of the repetition and in some of the reinforced messages today are coming through from, and almost thinking about, we talked a lot about language. And actually, I wonder whether there's something about complexity and sometimes the multiplicity of issues and the challenges and complexity, which are real and clearly issues, but whether that almost enhances the narrative, actually, that, oh, this is too complex an issue to solve. And I think that kind of runs through right from the way we do research. Oh, it's hard to read. It's really hard to engage. It's hard to reach. It's hard to do this. And I think Peter and Jill, you're talking about actually what do we need? And it might be simple things. It might be doing things differently. It might be thinking about the way we do research, which is kind of what everyone has shared today. Actually, do we need to think about how we do things differently in the way we reach people, in the way we collect data, and how we do things? And I think it's almost sort of wonder whether it's time to kind of maybe shift it from that, okay, let's turn that complexity and trying to break it down. Yes, it is a complex issue, but moving towards how we do things, but also thinking about that embeddedness right from the start. And I hope that, I think conversations like today, which will not be the last one, and there's lots more that we need to do, that hopefully that gives us a forum and ways to think about how we go about breaking down some of those challenges into more doable solutions and things that we can start to see smaller, and then hopefully later impact as well, and seeing how, I suppose, those smaller solutions can then be scaled up as well. There's the issue of there is the need, I suppose, for really scaling that up on a wider level. I mean, even things like digital poverty we talk about, but actually the flip side of that is there is scalability in that. If that's done well, it can lead to greater good and greater change. So we will pull the discussions we've had today together. We don't want this to be the end of conversation. I know that many colleagues here are also working in this area and doing lots of other excellent pieces of work, and hopefully this has been beneficial in sort of learning and sharing from each other, which is really what we want to do. And we'll try and pull this together and hopefully share this back not just with you, but you know, with others, that we can maybe use this to influence some of that change. So please do let us know if there are places where you think we can share some of this. We hope to put this together in the form of a blog or something more accessible. So drop us a line and say if there's anywhere through your networks you think this could be shared. We'll certainly share it through Fuse and colleagues here today. So yeah, just to say thank you so much for coming. It's been really energizing and great to see everyone and learn and share together. And big thanks to Fuse colleagues, Cheryl and Mark, Leslie and Anne and others for bringing us together and making this happen. Peter, Jill, and everyone for coming, really, and for making this making this an interactive and great session. Have I missed anything, Neha? Is there anything that we need to?
No, I think you've covered everything, Sheena, there is to cover. Just that we'll probably send you a link with when these slides and everything go up online. We'll share a link with these resources.
Great. Yeah.
Thank
And
you
maybe
so much.
next time we'll do something in person.
Oh, that would
Yes,
be
fingers
great.
crossed.
Yeah.
Thank
Lovely
you,
to see
everyone.
you
Thank
all.
you so
Thank
much
you.
for joining.
Bye.
Thank you.
Thank you.
Bye.
Thank you. Bye.